some advice, had a bit of a break, had some recharge time, and are now ready and willing to go for the 2024.1 RACGP KFP exam. I had a nice little break myself, thank you for asking. Spent some time with the family and recharged the emotional batteries. Of course, I've managed to get sick again, so it seems to be I've been sick more often than not this year, but the show must go on, and so we will carry on tonight and get back to our practice questions. Now we are 30 days, the final month before the KFP exam, and so really I want to make sure everyone's focusing in and getting as much practice time in as possible. About this time, really it is about refining your final technique, brushing up on those areas where you might not be performing as well as you want to be, and giving yourself as much time to practice, because it is the exam technique, I think, that lets most people down. So, practice. At this point in time, I want you to focus on doing as many practice questions as possible. And so some places to get more questions, if that's your biggest struggle right now, is GP Learning. There is practice exams available on there, and the modules from RACGP, if you haven't done them, you're doing yourself a disservice. No better source than the source itself. So I would log into GP Learning and actually go through all the material that they have on their site there. Of course, there's your paid programs such as GP Academy, ModMed. Oh, pardon me, we're off to a great start tonight. GP Academy, ModMed, KFP Bank, that you can also use. Now, these are paid services, and so there is going to have to be an exchange of coin there, but they often do discounted programs or cheaper programs if you're just trying to get access to their question banks. So if you don't have access to those, it probably is worth spending a little bit of money and getting those in now. Now, of course, the RACGP do release practice exams, and if you go through the exam reports, the people that do the practice exams do exponentially better on the actual exam itself. I think that's a familiarity thing, making sure that you're doing the questions that the RACGP wants you to be doing. They also provide you the answers and rationale for them as well, so you can make sure that you're on the right train of thought, you're on the same train of thought as what they're after. And although you're limited to the ones that they provide you, hypothetically, if you know other candidates that have come before you, you may be able to source some from others as well. But of course, we cannot condone that as per the college guidelines. Now, I know a lot of people spend a lot of time doing the RACGP checks, which I think are a fantastic resource for study, probably in the time before this last month. I think if you're just honing in on the checks now, you're going to have time better spent, I think, in other avenues. I think if you want to read through some of the checks, bearing in mind that I think a lot of the check material can be at a higher level of knowledge than what GP would be expected to know, but certainly a good resource to go to if you want to polish up on particular topics or conditions that you might not feel as comfortable with. And we've mentioned before as well, on generallypracticing.com, we do have the KFP case generator where you can put in a few basic details of a patient that you've seen. Nothing is saved, nothing is stored. It literally just spits out some practice questions to get you thinking about the patients that you're seeing and how can you apply that same style, that same knowledge base to KFP questions. Pardon me. Now, the whole point of doing these questions at this point in time really is to work out, well, what is your weak areas and what are the things you can be doing now to actually target those weak areas to turn them back to strengths. I want you to be honing in on the golden sources for all KFP questions. That is really ETG, AMH for anything to do with pharmacotherapy. And I want you to know those resources like the back of your hand. For anything related to paediatrics, most of the time you'll see answers pulled from the Royal Children's Hospital guidelines, and so I would strongly encourage you to be familiar with those. And of course, you're always given a couple of dermatological questions, and so if you go to DermNet, even if you just familiarise yourself perhaps with some of the photos, some of them may be familiar because they are a fantastic resource for photos, and they do have a photo bank, so if you're not using that, now is the time to jump on board there. Finally, we have an announcement from RACGP, and that is through the TMS system, you will gain access to the Australian Medicines Handbook and Electronic Therapeutic Guidelines. So at the moment, this is for registrars, not for fellows. And it turns out there's perks to being a registrar still. Make sure you log into TMS and follow through to have access to these resources if it's not something that you already have access to. All right, of course, we are here tonight to practice more questions. And so I think we will put our 2 minutes on the clock, and your time starts now. All right, so look, not an uncommon presentation. It's something that I think we've seen dozens of times in clinical practice. The question is, are you following the evidence-based guidelines? So this is a sneaky way to start to assess some of your knowledge around these common presentations that perhaps we've worked out our own ways to handle, but we need to fall back to what is best available practice. So here, in terms of lifestyle habits or behaviours that could exacerbate persisting fatigue, and particularly a young case like this, would be things like poor sleep hygiene. The common things are common, and we know that without good sleep, you're going to experience persisting fatigue. Unhealthy diet, and some of this may tie into socioeconomic status. We tend to presume that university students are probably living on the tighter budget, and so may not have access to fresh fruit and vegetables, or at least in quantities or supplies that would constitute an otherwise normal healthy diet. One thing students do have access to, he says from personal experience, is excessive caffeine intake, and I used to live off coffee. I still do, admittedly, but we know the people that have a higher end caffeine intake are more likely to have not only poor sleep but also increased fatigue. A lack of physical activity. The less active you are, the more likely you are to feel fatigued. Overcommitment. Now, they have mentioned here that she admits to having a hectic schedule due to university, but claims that her fatigue isn't solely due to academic stress. And so this would be something that would exacerbate. It may not be the sole cause, but I think would still be definitely counted as a potential answer in this matrix. Now, they haven't specifically said that there isn't other substances there, and so substance abuse being a valid answer, and I probably would go with an example in this category. So we have already highlighted here 4 to 6 drinks of alcohol on weekends is on the excessive side, and certainly can contribute to persisting fatigue. And there could be other substances involved. Lack of social supports. I think this would be a potentially risky answer, as there's nothing really to say one way or another, but probably more so that this question is specifically asking, and here we go, what lifestyle habits or behaviours might exacerbate. And I think you'd probably be a bit stretched to try and say social supports is a habit or behaviour. And of course, high stress lifestyle can certainly contribute to fatigue. For these kinds of questions, fall back to, what would you do? What would you say to the patient that's actually in front of you? What would be the things that you'd be exploring to try and work out what could be contributing to this fatigue? And I think as long as you're in that kind of pathway and on that train of thought, you're going to set yourself up for success. But of course, we have more questions. So, with 2 minutes on the clock, Your time starts now. Alright, so we have explored the lifestyle factors. We need to now think of what are the underlying medical conditions that we need to be worried about in the general practice setting. Lots to choose from. Now, these are taken from the RCPA recommendations and guidelines for investigations for fatigue. And so the things we want to be looking at here would be any kind of malignancy. I think if you give any kind of sensible answer on that kind of frame, you're going to be getting marks. Cardiac arrhythmia, or a suitable example, would also definitely be worth marks there. As well as any serious viral infections. So in this bracket in particular, you'd be looking at things like hepatitis C, HIV, or you could potentially put in something like Epstein-Barr virus or cytomegalovirus as well. I think anything that you're putting into that kind of bracket I think is going to get you marks. Pregnancy. We have a young female of reproductive age, and it's not specified otherwise that she's not sexually active, and so it would be something you would want to confirm or refute. And then we can get into the kind of other common things that we need to be looking into, so psychological causes, stress, anxiety, depression, or any kind of suitable example there. Now, you can have, and this is probably more where EBV and CMV would come into play, a persisting mild viral or post-viral infection with suitable example would also be getting you mark. We've already talked about impaired sleep, and so sleep-related disorders, or a suitable example, obstructive sleep apnea, narcolepsy, any kind of appropriate thing in here would get you marks. Cardiomyopathy, so starting to explore some of the more weird and wonderful things would certainly play in. And anemia as well. I'm always a bit hesitant to just write anemia, but it is a common cause and would be something that would be readily investigated. Now, I've kept this broad here, but again, in the actual exam, I'd be listing a specific example here. So iron deficiency anemia, for example, I think would get you more marks or be more appropriate than just a blanket anemia term. Hemochromatosis with excessive iron load can often present with fatigue, and you'd be exploring again other things associated with that. Bacterial infections, celiac disease or Crohn's disease, so inflammatory bowel disorders. There's nothing really here to kind of focus in on that, but would be something that you could consider in this age bracket. Renal failure would be rare but not impossible. And of course, any suitable metabolic disturbance, and so things again like diabetes would be more appropriate. In this case as well, being more specific, I'd be specifying type 1 diabetes, for example, rather than just diabetes on its own. All right, hopefully you've got some answers in there. But of course, we have more questions. So let's get 2 minutes on the clock, and your time starts now. All right, come on, guys. You all knew it was going here. You knew I'd ask what investigations would we do. And so here we've got, again, this is coming from the RCPA website in terms of their recommendations, as well as there was a common sense pathology paper put through from RCPA through to Australian Doctor with some RACGP input as well. And essentially, full blood count, liver function tests, TSH, renal function as well, and electrolytes are the basic recommendations to start off with. There is a bit of a push that if there's any concerns around sleep disorder to actually put through for polysomnography, but this question, if you read the question, is what initial investigations would you consider? And so these would be from this list, the three most appropriate ones. Now, I think the FBE in particular is going to get you 2 marks there because it's going to be best bang for buck to look into things like anemia as well as immune function to give you an idea, could there be some kind of infectious pathology occurring there as well. All right, of course, we have a whole new case coming up. So let's put 2 minutes on the clock and your time starts now. Oh, that didn't work very well. Let's go back one. There we are. Live video, you gotta love it. And we're having audio troubles tonight as well, which is just great. Okay, now let's get 2 minutes on the clock and your time starts now. All right, so here we want you to be thinking about what are the different conditions that could contribute to whole body pruritus. And this is one of those things that you will come across patients that present not infrequently. I wouldn't say it's super common, but I wouldn't say it's also a rare presentation either. And so, lots of things that can cause this, and obviously one of the big ticket items we don't want to miss out on is malignancy or metastatic disease in particular. So any kind of suitable example of metastatic disease would get you marks there. I think even just specifying metastatic disease, you're going to get marks. Of course, primary hepatic pathology, so cirrhosis, cholestasis, or any other kind of suitable example there is going to get you marks. Renal disease, in particular uremia, acute or chronic kidney disease, is going to get you marks. Type 2 diabetes mellitus, so in particular with a neuropathy, can present as whole body pruritus, or even just in an extreme hypoglycemic state. Some people present with itch. Thyroid disease. Hypothyroidism or hypothyroidism can both present with pruritus, in particular being whole body, although in some cases I believe you can have focal pruritus as well. Hematological disorders, I think the key ones here that you'd be wanting to focus in on is going to be lymphoma or polycythemia vera. We used a lymphoma question a couple of weeks back, for example, that I think I mentioned itch in there. I can't remember now. So definitely going to get you some marks. Psychiatric disorders with somatization, so depression, phobic disorders, in particular if you want to specify things like parasitophobia or obsessive compulsive disorder can present with itch or at least the scratching as a somatized symptom. And also neurological conditions, so a cerebral infarct, abscess, MS, brain tumours, all can present with itch. Again, you'd be probably expecting other things in there as well. HIV in particular, seroconversion can definitely present with itch, and medication adverse effect. Pardon me. So we have specified here that he is taking candesartan. We know ARBs through bradykinin mediation can cause itch as well. So if this is something that you think you might need to brush up on, there is a fantastic, a little bit older than I'd normally like to use, article from AFP about pruritus in the elderly, about how to assess what the red flags are and management options as well. But could that be a question coming up? Let's find out together. We'll put 2 minutes on the clock. Your time starts now. All right, so 2 minutes is up, and if we want to try and tease out exactly where this is coming from, we could be exploring things like the onset of the disease. So where did it start out? Did it start out in one location, then kind of expand out, or did it kind of start out as a kind of very confluent, suddenly spreading everywhere kind of situation? Aggravating or alleviating factors, so things that have been shown to worsen the rash or to improve the rash. If there's any rash at all, for that matter, actually, we should be specifying not all cases of pruritus will have an associated rash, and so that's going to be very valuable information. Of course, you'd also be wanting to find out what have you done so far, because people will put everything on them to help with rash. I've heard some weird and wonderful things. So I once had a patient that I was very concerned may have been jaundice because they came in fluorescent yellow, and I thought, oh, this is bad. They've got this whole body rash, whole body itch. The itch was benign, but they were putting saffron on themselves to treat that. So ask if they put anything on. Tied into that as well is use of any new cosmetics or creams. So is there something they've introduced to their routine that could be exacerbating this, as well as what is their background history of atopy, eczema, asthma, hay fever. Now that, if you try to put all those things in one, would definitely fall under overcoding. So I think just specifying one of those things shows that you're exploring that kind of atopy type history. Now, dietary history can be quite important for pruritus because what you're really investigating there is possible nutritional deficiencies. There's a lot of nutritional deficiencies that can present to themselves as pruritus there. And of course, environmental conditions. So looking a little bit further out from the patient themselves, are they having hot showers, heaters, electric blankets, all things that are known to exacerbate pruritus? And of course, are they around anyone that could be sick? In particular, it has some kind of itching condition, so things like rubella, mumps, varicella, for example. Now, I do have a little note here. Slide blurred, also previous answers were blurred. If that is the case, I would be checking the YouTube quality settings, having a look on my end. The data rate coming through seems to be pretty good. So not sure. I would be making sure you're watching at least 720, preferably 1080p. Let me know if that doesn't fix things up. And I just want to spend a moment as well to say, I hope your handwriting answers out to practice as if you would for the real exam. So I've said a few times, I want you guys to be pretending this is real, because writing for hours on end can be absolutely horrible. And so I want you to build up that muscle memory, that strength in your writing and legibility to make sure that you're not doing yourself disservice there. All right, we have one more question left on this case, so we'll put 2 more minutes on the clock and your time starts now. All right, time is up, and for these kinds of things, we want to be looking at what kind of simple things do we want to recommend to pretty much all patients with this condition. And so things like quick, cool showers, 2 to 3 minutes maximum, has a lot of evidence behind it. Likewise, we want to be avoiding other irritants, so using soap-free substitutes while showering, just patting dry skin, so we're avoiding any kind of friction or rubbing movement that can damage skin condition, and liberal use of emollients on damp skin after the shower. And so there may be some concerns about overcoating there. I think that those instructions as they are fine, because you're specifying the time frame that it's important to try and get that emollient in there. So something like QV cream, some paraffin-based, nice, simple, applied in big tubs, dirt cheap, can make a massive difference. And you could advise them to do that 2 to 3 times a day as well. Now, avoiding excessive heating in winter and avoiding use of electric blankets in bed, I think would likely be grouped together, because really we're saying avoid that overheating situation. And so I'd be specifying one or the other, probably not both. That would probably need to add more diversity in your responses there. Using a humidifier, if possible, to enhance the ambient indoor humidity to at least 40%, again, has a lot of evidence base to it, and minimising direct contact with woolen or synthetic garments, so things that we know are going to be irritating or scratching up against that skin there. Now, one of the big complications from pruritus is the damage they do to themselves. And so keeping fingernails nice and short with no rough edges to try and minimise the complications from scratching. And really the key one there we're trying to avoid is going to be those secondary bacterial infections. So lots of things that we could be targeting here. And this is one of those questions as well, this whole case really, where each question kind of follows into the next one. And the handy thing, and I've seen this a couple of times, you'll find some of these answers might actually prompt you to think back to the previous questions and give you additional responses to those previous ones that you may not have necessarily put before. So don't be afraid to, if you do kind of get that little spark of, one of the examples here would be avoiding use of electric blankets in bed. As you saw before, that kind of response could be appropriate in that last one as well. And so feel free to go back and forth and kind of add things as things come into your mind. All right, we are coming up to the final case for tonight. Let's get 2 minutes on the clock and your time starts now. All right, time is up. And if we want to be looking into things, and you'll probably notice a little bit of overlap between one of the earlier questions as well, what are the things that can mimic these kinds of episodes or induce them, or basically what are the things that we want to be excluding when we're talking about what seems to be at first glance panic attacks? So the big things you wouldn't want to miss would be cardiac arrhythmia. So paroxysmal AF would be rare but not impossible. I'd be thinking more along the lines of things like Wolff Parkinson White or supraventricular tachycardia. So I think having that is probably going to get you 2 marks there. Pheochromocytoma, particularly with that sense of impending doom, is one of the things that very rare, unlikely to be the case, but would be one of the things that you want to exclude as part of a workup here. Acute myocardial infarction, unlikely in someone so young, no other significant medical history, but would be something that would be, again, worth investigating, and you're going to get some overlap between your investigations for your cardiac arrhythmia and myocardial infarction. You'd certainly be doing a lot more kind of questioning and examination to try and rule in or rule out that one, but keep that in your memory bank. Hypothyroidism. You'll see that come up again and again, and for most questions in the KFP, you can sneak it in there somewhere. It's the great mimic. Poorly controlled asthma. We could actually be seeing exacerbations of asthma causing these symptoms here with palpitation, sweating, trembling. And tied into that as well, I'll skip on ahead a little bit, hypoglycemia. These can all be symptoms of hypoglycemia, so would be worth investigating further. Now, epilepsy, these could be partial seizures, and so again, you'd be wanting to explore and tease out a few more details about the presentation, as well as things like Addison's disease. So, again, one of the great mimics can easily be missed if you're not actively looking for it, and so teasing out a few more questions there. Now, tied into kind of the epilepsy and epileptiform type disorders, be looking into things like your TIAs or potentially CVAs as well. And I have seen a case not too dissimilar to this exact story that was actually serial TIAs from a patent frame in Ovale tying in some of our cardiac investigations, and so is something that you definitely don't want to miss. And of course, intracranial lesion or infection, less likely to be the case with this time frame, but lesion could be a potential thing here. Again, something you wouldn't want to miss and you would be wanting to tease out further. All right, hopefully you've got a few answers in there as well. Again, you'll notice there's lots more answers here than there are things that have been requested, which means that as long as you're putting down sensible things along these kinds of trains of thought, you should be getting some marks. All right. Next question. Let's get 2 minutes on the clock and your time starts now. All right, time is up. And I have been a little bit mean with this question, admittedly. But I wanted to focus in. You're more likely to get things like depression, anxiety, but any condition is fair game, and so there would be a basic familiarity with DSM diagnostic criteria. And part of this as well, if you look at a lot of the Medicare or PBS, billing criteria, they need specific diagnoses. And so you need to be able to say with medical certainty that this patient meets this diagnosis. So the DSM criteria for panic disorder would be recurrent unexplained panic attacks. Now, in the criteria itself, it does go through to list different symptoms of these panic attacks, but I think as long as you're saying these recurrent unexpected panic attacks, you're getting 2 marks there. Just recurrent panic attacks, you'd probably get 1 mark. It's the unexpected qualifier that I think adds that extra little bit of knowledge base there. At least one of the panic attacks has been followed by 1 month of persistent concern or worry about additional panic attacks is the second major criteria there. And hint, if you ever get these questions, DSM will pretty much always have the disturbance is not attributed to the psychological effects of a substance, and the disturbance is not better explained by another disorder. And so you're not going to get as many marks, but if you're really struggling and aren't sure what else to put, there's a few free qualifiers in there for you. All right, hopefully you have done well there. And I would be familiar, just passingly familiar with the diagnostic criteria for your things like major depression, anxiety disorder, and know what kind of ballpark things you would be placing or looking out for to meet some of these diagnoses here. I would say probably also be familiar with bipolar disorder as well, 1 and 2. But for now, let's get 2 minutes on the clock, and your time starts now. All right, so every now and then you get those questions where you're like, okay, I've got a feel for what's going on here. I think I know which direction this is going. And then they just seem to pull the handbrake and do a quick U-turn on you. And look, you've absolutely smashed it there. We are looking at imiquimod topical therapy or podophyllitoxin topical therapy. You can also use cryotherapy, which is good if there's just a few lesions. Can be quite uncomfortable given the anatomical location, but would be something that I would offer as well. Now, we have specified here, of course, that doses are not required. I think you probably would get perhaps more marks or show that extra little bit of polish if you do know the imiquimod's 5% cream or the podophyllitoxin's 0.5% paint. But I think if you just pop down the imiquimod or podophyllitoxin, I think you're going to get at least 1 mark there, so you should be pretty safe. Of course, this is taken from ETG as the gold standard source for these kinds of questions. Now, if this is something that you're not familiar with, and I know speaking to others, if you're perhaps a female practitioner that don't see as many males, particularly about genital things, this can be something you might need to familiarise yourself. Females can get genital warts as well, but certainly I think that it's, in my experience at least, being a male GP, I've seen many more male patients presenting with genital warts than I have female patients. So knowing what your target demographic is and how to best treat them is, I think, very, very important. All right. So that is it for tonight. We've gone through all 3 cases. Very well done. Again, congrats for sitting up on a Wednesday night to add to your study. I think it's a testament to how determined you are to get through this exam. Hopefully you have found these questions helpful. I'm going to continue to do these before each KFP exam, try and build up as many questions as I can to help prepare as many people as possible. And the things you can do to help that out is, of course, to spread the word, let other people know about it, because I do track things like subscribers and view counts to know, is this actually worth my time? And obviously, if you want to throw questions, comments, queries in the chat or into the comments section, it would be greatly, greatly appreciated. Now, on that note, we are coming up to 200 subscribers, which I thought was absolutely fantastic. I do want to do something to try and celebrate, and I've been trying to rack my brain to think what other things I could do. There's also YouTube community guidelines that I don't want to be breaching here. So I thought I will track down who the 200th subscriber is. I'll post the message somewhere in the channel to try and reach out to them. I can see the names of the people that do subscribe. And I thought one thing that could be nice is, if you don't have them already, I'm going to send you a couple of books to prepare. These aren't necessarily great for KFP, but when you pass the KFP, you're going to need practice for the CCE, and those books are particularly helpful for that. So let people know, and they might score some free books, I guess. Cool. Hopefully you have learned some things tonight. If you do have any other questions, comments or queries, feel free to reach out and get in contact with me. I want to make this as interactive as possible, and I want to make sure that if you have things that you are struggling with, that I can try and tailor some of what I'm doing towards that. Ultimately, I know what struggle I had passing the KFP was, and I want to make sure that people don't have to go through that same thing. So that's my little spiel once again. Cool. So without too much more ado then, we'll probably wrap it up here tonight. And oh, great. No, thank you very much. It is good to hear that people are finding this helpful. But you probably all want to go to bed, don't you? What are you doing here? You have lives, you have families. This is why we do it at the end of the day, isn't it? So thank you guys, and I will catch you again 8:30 next week. Hope you have a great week between now and then. If you get interesting cases, write them down, practice them for KFP questions, and get ready to smash this exam. The final month, guys, the countdown is on. See ya.